फुल स्क्रीन कर दो, फुल स्क्रीन में कर दो। ये स्लाइड, नेक्स्ट स्लाइड वाला चाहिए नहीं।
स्क्रीन नहीं, स्क्रीन यार ऐसा
ये तो ऐसे नहीं होना चाहिए। Well, okay, today we are going to discuss about M.B.B.S. And well, M.B.B.S is a condition which is very common in our country. And the extent of how much M.B.B.S we have is really not very clear because of the fact that no real clear-cut surveys have been done, or no clear-cut. There are symptoms which mimic various diseases, and hence getting a proper survey done becomes more and more difficult. So we will try and cover this topic, and let's see what in whatever estimates which have been made of the population, we'll try to see how the disease is spreading in our country, what steps we have taken to try and control this disease. It's a very difficult disease to control, and let's see how we have done that, and we'll see. This is there is let's next. Okay, so so amoebiasis has been defined by WHO as a condition of harboring the protozoan parasite Entamoeba histolytica with or without clinical manifestations. As is common in various other diseases, we will have people who have the disease but are not suffering from the disease, have the protozoa but do not suffer from the disease. So the symptomatic disease occurs in just less than 10%. So 90% of people are asymptomatic, and that is the problem with this disease. So it is spread. There's a huge asymptomatic population, and hence the spread is very, very common. So the intestinal disease varies from mild abdominal pain to acute fulminating dysentery. You are also aware that there is the intestinal variety of amoebiasis as well as the extraintestinal. You have taught all these things in microbiology and in pathology. The extraintestinal disease includes involvement of liver, lungs, brain, spleen, etc. So we have Entamoeba histolytica is worldwide in prevalence. It is more common in tropics, but it has been found wherever sanitation is poor and in all climatic conditions. %10 of the world's population and 50% of the inhabitants of some of the developing countries are considered to be harboring the parasite. A large majority of the infected are asymptomatic, as we said, 90%. So the invasive amoebiasis causes disabling illness in estimated 50 million persons and death in about 50,000 annually, mostly in the tropical belts of Asia, Africa, and Latin America. The incidence of the amount of deaths from amoebiasis has gone down tremendously due to rampant use of antibiotics, rampant use of metronidazole, tenofovir, etc. There's widespread use, and hence that's the reason why the incidence of deaths has decreased. So prevalent rates may vary from 2% to 60% more in areas which are devoid of sanitation. Basically, as you've learned earlier, amoebiasis is transmitted through water, food, and other products which is there. And it is basically not the trophozoite form, but the cystic form which which will cause disease. We'll talk about it. In areas of high prevalence, it occurs in endemic forms as a result of high level of transmission and constant infection. So epidemics occur if there is heavy contamination of drinking water. In India, the M.B.B.S affects about 15% of the Indian population. Why have we gone to this? Yeah. Why is it that we are not getting the full screen here? Okay, we'll run it like this. I think there's some problem with this particular laptop. I don't know why we're not getting a full screen here. But, okay. Okay, M.B.B.S is in India affects about 15% of the Indian population and is reported throughout India. Prevalence rate is about 15%, ranging from 3.6 to 47.4% in different areas. It depends on various areas. Depending on the sanitation of that particular area, you will find that the infection rates are more. Okay. The agent factors, Entamoeba histolytica. Not all the strains of Entamoeba histolytica are pathogenic or invasive. So you differentiate between the pathogenic and the non-pathogenic strains by doing a complement-mediated lysis or a phagocytic activity, or by use of genetic markers, or doing a monoclonal studies. So all these ways you can differentiate between a pathogenic and a non-pathogenic strains of Entamoeba histolytica. Electrophoresis mobility, also you can then detect the 6 isoenzymes, and these are classified into 22 zymodynes. You're well aware of all these things which you have learned in microbiology. So 9 invasive or pathogenic strains, and the rest are non-invasive commensals. So these zymodynes which are there, they show geographical distribution, and the non-pathogenic ones are far more common than the pathogenic ones. So it occurs, as such, Entamoeba histolytica occurs in, as you're aware, in 3 different forms: trophozoite, pre-cystic, and cystic. The life cycle, you have, this is how a trophozoite looks in trichome strain, which you have done in microbiology. The trophozoite, or the vegetative form, is the growing or the feeding stage of the parasite. It is large, actively mobile, and freshly passed dysenteric stools, while in convalescent carriers it is much smaller. So this is how we can detect it in the stools of patients. And trophozoites are delicate organisms and killed by drying, heat, and chemical disinfectants. However, they do not survive in stool outside the body. Therefore, the infection is not transmitted by trophozoites. You're aware of that. Trophozoite is not the one which transmits the disease from person to person. Person to person, the transmission takes place through the cystic form, not by the trophozoite. Trophozoite form, if it is eaten, you consume it, the body, the acids which are there in the gastric in the stomach, you will kill this particular trophozoite. Okay, yeah, here it is. Even if live trophozoites from freshly passed stools are ingested, they are rapidly destroyed in the stomach and cannot initiate the infection. You can, these are the pre-cystic form and the cystic forms. These are the ones which possibly can transmit the disease. Before encystment, the trophozoite extrudes its food vacuole and becomes round or ovoid. And this is how it is: cyst of Entamoeba Estolytica in iodine stain or in trichome stain. You have done this in microbiology. No need of me going into details of it. So the cystic stage, the pre-cystic secretes a highly refractile cyst wall around it and becomes a cyst in the intestinal lumen. So the mature cyst is quadrinucleate, and these cysts are infective form to man. These cysts are relatively resistant. They can survive for several months. These very important for you to remember this. They can survive for several months in water at lower degree, this thing 0 degrees or for 3 days at 30 degrees centigrade. They can survive for several months in water at 0 degrees. They can survive for 3 days at 30 degrees and 30 minutes at 40 degrees centigrade and 5 minutes at 50 degrees. So very, very resistant, very, very resistant, if you can say. In grossly contaminated water and sewage, they may survive even longer. They remain viable in moist soil for up to 10 days. So this is as such the you can see the complete cycle. The mature cysts are consumed by man, and then there's a process of the formation of the trophozoite, etc., which is there at the in the intestines, and then after that in the feces, if the cysts are formed, the pre-cystic form comes out in the feces. Then the cysts are formed, the multiplication takes place, and then you can have again the cystic form, the mature cyst form. You're aware of all this. Okay. The reservoir of infection. Man is the only reservoir of infection. The intermediate source of infection is the feces containing the cysts. And most individuals infected with Entamoeba histolytica remain symptom-free. I told you about 90% of them, and are healthy carriers of the parasite. The carrier can discharge up to 1.5 into 10 raised to 7 cysts daily. So it is a huge amount of cysts which are discharged. Period of communicability: as long as the cysts are excreted, the period may be several years. And if carriers are present, unrecognized, and untreated, you can have these being communicated for years together. So that is the whole problem. 90% of individuals are not showing symptoms, and once they are not showing symptoms, they can carry on giving cysts for several years. Host factors can occur at any age and occurs in both sexes, is frequent household infection, and when one person in the family is infected, the others can easily get infected. Immunity: cell-mediated immunity plays an important role in controlling the recurrence of this infection which is there. The environment factor: basically poor environment, poor sanitation, poor water supply, poor storage of water rather. So M.B.B.S is closely related to poor sanitation and socioeconomic status. Poor socioeconomic status is a result in person living in unhygienic conditions, and that will be the problem. Use of light soil for agriculture will create further problems. And today, I must add in this is, today we have various colonies, various societies which are using the sewage water. Sewage treated water is being used in flushes, in gardening. So you can land up with amoebiasis very easily due to this particular problem. Infection rates are higher during the rains, and epidemic outbreaks are usually associated with seepage of sewage into the water supply. So the fecal-oral route is the intake of contaminated water or food is the most common source of infection. Vegetables, especially those which are eaten raw, you see many of these vegetables are taken in the fields. They are once it is harvested, they are washed, and this washing takes place many a time in sewage contaminated water. So it is very essential that when we get the vegetables home, we must wash them well, and also try not, especially those vegetables which are to be eaten raw, salads, etc. These are the ones where you have the biggest problems. Viable cysts are found on hands or under fingernails, everywhere. That's where what is basically it. Sexual transmission by the ororectal route is also recognized, especially among the male homosexuals. Vectors such as flies, cockroaches, these can, through mechanical transmission from one place to another, mechanical transmission, these cysts are carried to contaminated food or water. The incubation period is 2 to 4 weeks or a little longer maybe. Amoebiasis as such denotes all the conditions in the human host by infection with Entamoeba Estolytica at different areas of its infection. So if we start dividing it, amoebic dysentery is a condition in which the infection is confined to the intestinal canal and is characterized by the passage of blood and mucus in the stool. Pathogenic lesions are of two types: primary or intestinal lesions and metastatic lesions in the liver, lungs, brain, skin, etc. So let's deal with intestinal infections, which are the main infections. Which are 10% of infected persons develop dysentery. 10% of infected, as I told you, symptomatic is only 10%. 90% are asymptomatic. So there are these particular zymodymes which are pathogenic. Of these, 2 and 11 are the ones which cause liver abscess. The two classical tests to identify the pathogenic strains are ability to cause cecal ulceration in weanling rats, agglutination by lectin on covalent A. Now, one must remember that person, what does he report with? He reports as a case of diarrhea, or he will report with intermittent diarrhea and constipation. These are classical features of M.B.B.S. No other features which is there. Many a time, most of the time, there is no fever, there is no other feature which is there. So one has to look at the symptoms and then try to do various investigations. And various investigations which are there, one is first investigation which you do is to take a warm stool and try to look for trophozoites in the stool or cysts of M.B.B.S. in the stool. Also, one can go in for doing, if necessary, to do a colonoscopy to check for ulcers. We'll talk about those further. Pathogenesis of M.B.B.S. The factors responsible for amoebic invasion are cysteine proteinases, which break down proteins of extracellular matrix; lectin, which is on the parasite surface that binds to the carbohydrates on colonic epithelial cells in RBCs; and the channel forming proteins called M.B.B.S, which forms protein ion cell channels in lipid cell membranes and lyses them. All this you'll have dealt with in microbiology, so I'm not going into details of it. But what we are concerned with is it is rampant, and the host factors which can aggravate it is stress, malnutrition, alcoholism, steroid therapy, and immunodeficiency. All these things can predispose a person to amoebiasis. The pathogenesis of intestinal lesions. Initial lesion is in the colonic mucosa, most often cecum or the sigmoid color. And there is a slow transit of the intestinal contents in these two locations, which is an important factor in lesion. Binding to colonic mucins blocks the adherence to mucosal cells, and depletion of the mucus results in binding to the mucosa. So this is how the pathogenesis is there. You have studied this all in pathology. No need of going into this. Distribution of the ulcers. The ulcers can either be distributed generalized or localized. And the earliest lesion is the formation of scattered areas of small nodular elevations having an opening in the center with hyperemia and edema of the marginal tissues. Very, very classical. You can see these things. You find initial nodules which are there, which are hyperemic in nature, edema at the marginal regions, and the small opening. And below that small opening, then we will start getting that flask-shaped ulcer, which is classical of Amoebiasis. Later stages, brownish yellow necrotic material comes out in which trophozoites may be found. Intervening mucosa may be between the ulcers, may be not. So if you can see here, you have this whole, there's a flask-shaped ulcer which is being formed on the right-hand side, flask-shaped ulcer which is formed. And when you look at the lesions which are there, you have these pinpoint nodules which then start getting ulcerated, and you may go in further into problems. A typical amoebic ulcer has following characteristics, which is size varying from pinhead to 1 inch or more in diameter. The shape is round or oval, transverse in large coalescing ulcers. The margins may be ragged or undermined, being formed by the overhanging mucous membrane. On vertical section, you'll have, as I said, a flask-shaped appearance, flask-shaped. The base generally formed by muscular coat and filled by necrotic material, yellowish or blackish slough. So this is a typical ulcer which is there, flask-shaped ulcer. And these extension of the ulcers, we might have superficial ulcers, do not extend beyond the muscularis mucosa, and deep ulcers confined to submucosa or extend laterally. So this is, in this particular case, you can see this large ulcer which is there. So the healing of the ulcers, small superficial ulcers, you can have a complete restoration can take place. Large ulcers, scar formation may occur because of the deep damage which is there. And otherwise, you can form, there can be an amoebic granuloma or amoeba as it's called, which is there in chronic intestinal amoebiasis, tumor-like mass of granulation tissue. Microscopically, at the center, there is necrosed tissue in which occasional amoeba may be seen. And at the periphery, you have trophozoites seen in large numbers extending to the surrounding healthy tissues. What about amoebic liver abscess? Now, the trophozoites are carried to the liver by the radicals of the portal vein from the base of the amoebic ulcer. And first, you'll have amoebic hepatitis, which then later followed by abscess. Amoebic hepatitis is enlargement or congestion of the liver seen in the early stages. Necrosis is not advanced. And the precursor to the amoebic liver abscess. The microscopic appearance is reddish brown in color with semi-fluid or grumous consistency. That is what is there in the abscess. So microscopically, you have three zones to be differentiated. One is the central zone of catalyzed granular material, no amoeba in that. The intermediate zone has got degraded liver cells, leukocytes, RBCs, connective tissue cells, and trophozoites. And the peripheral one, which has got congested capillaries with necrosis of liver cells. Amoeba are seen in active multiplication. The pus of the liver abscess is not suppurative, but it is a mixture of liver tissue and blood. That's the reason why the color is that. You've got liver tissue and blood together along with and the slough which is taking place, chocolate brown in color and thick in consistency. So as typically known, anchovy sauce. Anchovy sauce. We have never seen anchovy sauce over here. So we know that it is chocolate brown in color and thick in consistency. So this is the classification of amoebiasis. I'll just go through it. The symptomatic intestinal infections, you can have amoebic dysentery, which pathophysiologically you have got the ulcerative intestinal problem. Non-dysentery gastroenteritis, again with the ulcerative intestinal disease. Amoebooma is a proliferative intestinal disease, and complicated intestinal amoebiasis where you have a perforation, hemorrhage, or a fistula. And post-amoebic colitis, which takes place, which nobody is aware as to why it is so. And then you've got the extraintestinal forms where you have non-specific hepatomegaly, acute non-specific infection of the liver or with or without abscess, or you can have amoebic abscess, which can get complicated, or you can have amoebic infection of the skin, amoebic cutis, or a visceral amoebiasis of the lung, spleen, or brain. So what will happen in intestinal amoebiasis? The mucosal erosion causing diarrhea, which increases the severity with increasing area and depth of involvement. More distal the lesion is in the colon, greater is the likelihood and severity of symptoms. So if it is distal, more distal in the colon, you will have more problems. Small rectal lesions are more likely to be symptomatic than larger cecal lesions. So the rectum is right there, and so it may be more symptomatic. Rectal bleeding is only slightly less common than diarrhea. Urgency, tenesmus, cramping abdominal pain, and tenderness. These are the signs which are there of amoebiasis. Extensive intestinal ulcers, when they are there, can result in perforation, local peritonitis, hemorrhage, or a proper perforation and general peritonitis. Pericecal and pericolic abscesses, sloughing and gangrene of the large gut, and stricture of the intestinal canal. This is a resected colon with amoebiasis. Clinical features, as we said, in amoebic liver abscess located in the posterior superior surface of the right, generally in the right lobe of the liver. So you will, because the right lobe is involved, you'll find the left lobe which gets hypertrophied. Onset is insidious. Pain and tenderness in the right hypochondrium. Pain is referred to anything which takes place in the right hypochondrium referred to the right shoulder, because the phrenic nerve gets involved, and then we get referred to pain which is there due to the irritation of the phrenic nerve. And fever may occur with amoebic liver abscess. You will or may if the abscess is large, you will definitely get fever. Because the liver is damaged, you can get jaundice, and especially so if the abscess compresses the bile duct. An abscess is located under the dome of the diaphragm. There may be an elevation of the dome which presses against the right lung, causing atelectasis and findings of consolidation. So this is amoebic liver abscess. As the abscess nears the diaphragm, the inflammation may stimulate pleural effusion. On examination, you'll find the lower border of the liver is palpable below the costal margin and is tender. Liver dullness may extend upwards. The left lobe undergoes compensatory hypertrophy. As I mentioned, right lobe is mostly involved, so left lobe does a hypertrophy. Pleural pulmonary or pericardial effusion occurs as a result of direct extension from the liver. This is the perforated amoebic liver abscess through the skin. Abscess can drain into the bronchus, leading to reddish brown pus being coughed up, or you can get a pericardial infection, which will give the apical pus may be displaced upwards and laterally by a large abscess. Amoebic abscess of the brain can occur, cause a severe destruction of brain tissue, and is fatal. Cutaneous amoebiasis occurs by direct extension around the anus. colostomy site, or a discharging sinus from abscesses. There is extensive gangrenous destruction of the skin wherever there is an ulcer, and the lesion may be mistaken for condylomata epithelioma. It is not condylomata, it is M.B.B.S, so one must differentiate. The lab diagnosis, as we mentioned, you must demonstrate Entamoeba and tissues, the discharges of lesions. Intestinal amoebiasis, stool sample should be taken, and then we must make sure that we stain it and see. Look for cysts as well as protozoa. Prior administration of anti-amoebic drugs, bismuth, kaolin, or mineral oils will interfere in the shedding of the trophozoite. So one must be careful that you take sample early. Macroscopic appearance, stool is copious, semi-liquid, brownish black in color, and contains foul-smelling fecal material intermingled with blood, and it is acid in reaction and does not adhere to the sides of the container. So these are typical features of the macroscopic appearance of the stool. Microscopically, you have got cellular exudate, scanty, consists of few pus, epithelial and cells and macrophages. Red cells are aggregated and yellowish and brownish red in color. In freshly passed motion, actively mobile trophozoites may be seen. Presence of ingested RBCs clinches the identity of Entamoeba histolytica. So, ingested RBCs, if they are seen, you can clinch the diagnosis. Culture and serology are not routinely employed, but if they are employed, you can get positivity. For detection of carriers, stool examination is done after saline purge for trophozoites and cysts. Concentration and repeated stool examination when necessary as excretion of amoeba is very irregular. Extraintestinal, you might find stool examination is negative. Diagnosis is based on serological tests, and serological tests which you do a complement fixation test, indirect hemagglutination assay, latex agglutination, gel diffusion precipitation, cellular acetate membrane precipitation test, and counter immunoelectrophoresis, and ELISA. These are the tests which are done. And in these, the indirect hemagglutination and the latex agglutination are highly sensitive but often give false positive results, while you have the gel diffusion precipitation is less sensitive and more specific, while the ELISA is both sensitive and specific. When in case of abscess, you may do a diagnostic aspiration, and the pus should be taken to the periphery, and this may not contain the amoeba. So this is the difference between amoebic dysentery and bacillary dysentery. Onset in case of bacillary dysentery will be acute. The fever will be present, toxicity will be present. There will be a generalized tenderness, while in amoebic it is localized. Then there will be no tenesmus. Frequency is about 40 per day. In case of bacillary dysentery, it's got plenty of motions, while in amoebic dysentery, you've got just about 6 to 8 motions per day. Odor is offensive in amoebic dysentery. Color is dark red. Feces mixed with blood and mucus. And then in bacillary, there is hardly any mucus. Consistency, you have got it adheres to the container in bacillary dysentery, but it doesn't adhere in amoebic dysentery. Prevention, you have health promotion, specific prevention, early diagnosis and treatment. Basically, the safe disposal of human excreta and sanitation. And you must give good potable water, hand washing before eating, defecation, sanitary items should be constructed. Water supply, protection of water supply from fecal contamination, using safe and clean water for drinking and preparing food. Water must be boiled or filtered. It's very, very important that we must filter our water. Do not drink water from public water fountains or from gardening water. Water must be made safe by filtering it through 1 micron or less filters. So food hygiene, we put in some slides of food hygiene. Basically, in the COVID environment, we are ensuring that we wash everything before eating. That's very good feature. But despite that, you'll find salads are not washed, which is the wrong thing. You must ensure that salads, hands, utensils, everything is washed well. Do not leave leftovers for more than 2 hours outside. Since food handlers are more transmitters of M.B.B.S, they should be periodically examined, treated. And street vendors, etc., they will convey much more cases. Flies should be controlled, health education should be done. Early diagnosis and treatment is the hallmark of any good preventive work which is done. So these you do various tests, indirect hemochlorination, counter 1, erythropoiesis, and ELISA technique. Now, treatment, what do you do? The treatment generally, as far as treatment is concerned, for luminal amoebiasis, we prefer to use dioxazonide furoate, 500 milligram every 8 hours, or 3 divided doses for 10 days. The mechanism of action, it destroys the trophozoites and prevents it from converting it into cysts. Metronidazole is used and tinidazole is used. Metronidazole 800 milligram tab every 8 hours in 3 divided doses for 5 days. We'll talk about tinidazole later, so I just mentioned tinidazole here for treatment. If the dysentery is severe, it can be combined with tetracycline or to reduce the perforation of peritonitis. Mechanism, it does not penetrate the mammalian cells. It in parasites, toxic oxygen species are secreted with damages to DNA. Let's leave this. Side effects. Generally, with all these medicines which we are using, metronidazole, tinidazole, all these medicines, we don't have very many side effects except for the fact that there is taste in metallic taste in the mouth and urine is darkened, and it has an effect on the alcohol metabolism. So the advice which you'll give to the patient is, please do not use alcohol when you're taking these tablets. So you should avoid an hepatic impairment and encephalopathy, contraindicated in pregnancy during the first trimester. When there is hepatic abscess, you're going to use metronidazole 400 to 800 milligrams for 8 hours, 5 to 10 days. And may or may not be required to be repeated after 2 weeks. Aspiration of the abscess may be required and increases the drug penetration into the abscess. Or tinidazole 1.5, instead of metronidazole, you can give tinidazole 1.5 to 2 grams in 3 divided doses for 3 to 6 days. This may be followed by dioxazonide if you do it. Contacts, you should try and do a fecal screening, especially in their institutions. Cases are confirmed and they should be treated. Dioxazonide furoate 30 to 40 milligrams body weight for 10 days, 650 milligrams 3 times a day for 20 days. Okay, environmental measures are very, very important. You must ensure the public water supply is clean. You must ensure that there is no contamination. Investigation of food preparation, drug practice should be seen so that it's not that we're using raw vegetables for salads which have not been washed in sewage water. So all these things should be looked into. In event of clusters taking place, which is very rare, you can confirm the diagnosis, undertake an epidemiological investigation to get to the source, and take appropriate measures to control and prevent the disease. Well, that's all that I have for you today. I hope you have understood this particular um, laptop is giving me trouble, so I'm sorry if you've had only the screen which is showing partially the particular slides. Okay, thank you very much, and see you next Monday with some more um, some other topic. Most probably I will be dealing with intestinal helminthiasis. So please read up intestinal helminthiasis, and then we will talk about it next Monday. Thank you.